everyone. My name is Sean Kopp, and I'm Manager of Events at OACAS. Thank you for joining us for the 2014 Annual Report of the Pediatric Death Review Committee and the Deaths Under 5 Committees. As a reminder, you've been placed in muted mode for this webinar. We will open the lines up a little bit later for a Q&A session, but would encourage you to make use of the chat box in the lower right portion of your screen for any questions. I'm pleased to welcome and introduce the presenters for this morning's webinar, Dr. Dirk Huyer and Jessica Diamond. Dr. Huyer has been a coroner in Ontario since 1992 and was appointed Chief Coroner for Ontario in March of 2014. Dr. Huyer has specific expertise in medical evaluation of child maltreatment with previous appointment on the Suspected Child Abuse and Neglect Program at the Hospital for Sick Children. He is the chair of both the Deaths Under 5 Committee and the Pediatric Death Review Committee. Ms. Diamond joined the office of the Chief Coroner in June 2014 as the Executive Lead Child Welfare and is coordinator of the Child Welfare Pediatric Death Review Committee. Ms. Diamond has worked in the Ministry of Children and Youth Services for almost 10 years with a focus on child welfare policy and operations. Good morning and welcome to you both. I'd now like to turn it over to Dr. Huyer and we can begin this morning's presentation.
Thanks very much, Sean. Thanks very much to everybody who's joined. It's always a challenge to do the webinars. Thankfully, it's just mere shadows of myself that I can see on the screen, so that's a good thing. So we're going to jump right into this. We'll hopefully have lots of time for questions after. I can imagine you've all gone through the whole report in great detail, so all your questions will be of value, and we encourage you to provide those to us. So we'll move on to the first slide. We already have released a report. As you know, we did release it this year only in an electronic form. Previously, we have had printed copies, which we sent out to the agencies, and we also did have flash drives that we've utilized in the past. But given the sophistication of electronic media in most places and fairly rapid download, we've moved to completely having it as a PDF format and available through our website. So you're free to print that as you wish, but otherwise there aren't any printed copies available. Go ahead, Emily. So just to give you a quick run through of where we are and where we're at, and many of you this will be repetitive, so do a couple emails and then join back in. The Death Investigation System in Ontario is a government organization, as you all know, and we're a division within the Ministry of Community and Safety and Correctional Services. There's often, not so much in the child welfare sector, but often confusion within the general public where people think that we're under the Minister of Health. But we are a public safety organization, even though we are physician-led and physicians do the majority of the death investigation or lead the death investigation system. We are specifically separate and distinct from the Ministry of Health, and all our funding comes from the Ministry of Community Safety and Correctional Services. In Ontario, we have kind of two general categories that we would be involved with to investigate a death. And if you look at the overall numbers and consider that there's approximately 90,000 people that die each year in Ontario, whereas the coroner's office will get involved in about 15,000 of those, so just under 20% actually, and as opposed to the number that we've put in there. And the two categories are anything that's non-natural, so any external factor that may have contributed, and the easy ones to think about would be any violence, such as a homicide or a car crash or something of that nature. Those ones we're always involved with by law. And then secondarily, we frequently are involved in natural deaths where they're sudden and unexpected, because early on we don't know exactly why those deaths have occurred. Ultimately, when you look at our numbers in the end, our total case volume, about 75% of the cases will turn out to be natural deaths. And just again for context, from a homicide perspective, about 165 a year in Ontario. So that's a fairly small number for our population, not necessarily stating that that's a way to measure the safety in the province. Now, looking at that 20% or even a little bit less of our overall death investigations, in pediatric deaths, which are up to the 19th birthday, we're involved in 35%. So certainly a greater percentage in pediatrics we'll be involved with, or child and youth is a better way to phrase it. And that's because there's a smaller percentage of those cases and deaths such in child and youth deaths that would be expected from a natural disease process. Whereas our population ages, more natural disease, more deaths from those. So that gives you an idea about the difference. But it also gives you an idea that pediatric deaths, child and youth deaths, are more complex and have more significant factors involved. So we have specific investigative procedures and processes specifically relating to children, but we also have expert death review committees, and you're aware of both the Pediatric Death Review Committee, which has two components, the child welfare and the medical component, and the Deaths Under 5 Committee. Both of those committees report to me, so I report to myself, and it's easy to do most days. And I have, on a personal note, I've considered stepping down from the chair because I'm the ultimate receiver of complaints, but at this stage and in the current process that we're in, I have not done that, and I don't anticipate doing that in the near future. Jessica doesn't know that, so I just told her that right now. But we're in a process of renewal and evolution of these areas, which we'll talk a little bit more about, but during that process I anticipate that I'll be present within, although it really depends on a variety of competing priorities. Our goals always at the office is to contribute to death prevention in any way. So is there something we can learn from the untimely or the tragic death that may allow us to make recommendations to change things that might reduce the chance of something similar happening for the future? That needs to be through careful review and discussion, and the death review committees help us to have further clarity by bringing experts together and use their lens to look at the death situation circumstances. So when you look at what is reviewed, it really is subsets of data or subsets of cases and the data that arises from those. So the deaths under 5, we have made a decision that we will have a case set or a set that we investigate them all, which is all deaths where we're involved to do a death investigation. So it's any time a coroner's involved, those cases will be reviewed by the committee, and you'll see a breakdown in a minute about the numbers. I've talked already about the two sections, but just to delve down a little bit more, the medical child welfare, the medical PDRC portion reviews generally cases where there's medical care issues that might have been identified to try to bring those up to a systemic level and help the healthcare system improve their services towards kids. And there really are unique things that are often seen, specifically in the area of pediatrics, and those are outlined within the report, and I'll touch on those a little bit later. You know about the joint directive, or you should know about the joint directive. If you don't, we'll remind you that there must be a report to our office and to the ministry when a child dies where that child, the youth, or the family was receiving or had received services from a society over 12 months prior to the death, anytime during that 12 months. Thanks. So far in 2013, you all, I'm sure, enjoyed and recall the fine presentation of the release of the addendum back in September of 2013. One of the big things that we touched on around that time and in the last annual report is that we really are moving as an organization towards data-driven death review, or even better, the terms that I like to use is data-driven public safety. So we are taking a number of steps organizationally, both from a culture perspective, but also from information management perspective, and a variety of other ways to work towards data-driven public safety. And that really has started, and Sean's just crawled across the floor in front of me. I could not laugh at that. And so we are taking a number of steps, and that's reflected in our approach in the annual report about our move towards data-driven and evidence-based approaches. Other things that occurred, I'm continuing to talk with my colleagues in the national level, so provincial and territorial level, about trying to improve data collection across the infant death area to really define better our understanding of those deaths, because there are so many challenges in truly understanding why infants die at times. Fairly large inquest into the death of Jeffrey Baldwin, and we're coming up about the 1-year anniversary of that. There was talk and there was a recommendation, just for your information, that the Office of the Chief Coroner should pull together a press conference to see how the recommendations are coming. We will not be doing that. It is not my approach, or is it the approach of the Office of the Chief Coroner to be using the media or using a forum such as a press conference to potentially be pulling or calling people out in their approach to the recommendations. We do request responses, and we will make those public, or we will provide those to the public as they're asked for, but we will not be doing a press conference despite that recommendation. And that's been disseminated fairly recently to the parties and also to the media. So you may hear about that the office is not doing that. Thanks. So as I've touched about data-driven public safety, the division generally made up of the Office of the Chief Coroner, the Ontario Forensic Pathology Service, and our Operational Services branch. The three of our organizations are all working together in an integrated way, in a collaborative way, to provide the highest quality death investigation system that we can. And that data will be valuable to, number one, the investigators and the families. The families are our key stakeholder as far as really learning the outcome of a death investigation and understanding the circumstances of those, because no one can imagine, well, many people have suffered losses, but when we're involved in those, it's hard to imagine the distress and the sadness that's occurred from their loss. And we strongly want them to understand to the best of our ability what's going on for their family members, and help them to understand that perspective and what might be done differently, or what will arise from those. So that's the individual level, and clearly important to an investigator. And if you take a homicide, for example, you know, the forensic pathologist doing a detailed autopsy, understanding fully the mechanism of the death and how that death occurred, is of great value to the investigators and also to the criminal justice system. So that's some examples of an individual. But more equally as important, and a different kind of important, but equally as important, is aggregate of that data. So each of those death investigations having high quality information, full understanding, then joining those together to help bring those data sets together to really inform broader understanding of death and risk and how to prevent things in the future. So those aggregate can either be similar cases, it can be data over time, which can be similar cases or different cases. So for example, other cases would be all different kinds of child deaths, so you bring that together to children. Data over time could be something of a similar type, like how often heroin causes death over time, and then comparing similarly to other jurisdictions. So there's a variety of different methods of how to compare things, and we'll talk about some of the approaches that Jessica led for this annual report, and how to do comparisons so people have understanding and context of what's going on. And what we're ultimately doing is, as we're moving forward along with the data-driven public safety, we're trying to figure out who is the best people to receive this data. And so we're developing relationships over the next number of years and immediately, but also as we go forward. And this is an example of such, of sharing the data with folks who will be able to understand, but also utilize that to impact your approaches to things, policy development, and future research. So we've taken a different approach for our data analysis. Typically, when you talk about the child welfare portion, we've focused, well, not typically, we always have, focused on the cases that are reviewed specifically by the committee. We've talked about the other data, but we haven't analyzed the other data, and you'll see as we flow through what I'm talking about. If you think about some numbers, every year about 100, somewhere around 100 deaths occur of children and youth where the society, and I'll use general society, where the Children's Aid Societies were involved in the death, with the family or the child at some point over the 12 months. It's a fairly stable number, actually, from year to year. So what we've done is we focused much of the analysis on those, in this case 96, but the 100, the overall case numbers where Children's Aid Society had some involvement over the calendar year of 2013, because it is a capturable data set. The significance of the data set is hard to know for sure, except that we know that there's death and there's Children's Aid Society, and those two things are what's defined the data set that we're using for analysis. So it's just an example of showing you how you can target and focus your analysis in some way when you do things, if we in fact think there's some context. Next. The other thing that we've obtained this year, again through initiative that started this year and a good outreach, is to understand what's going on provincially. So we reached out to Service Ontario, which is the organization where the Registrar General for Ontario is based. The Registrar General is the person or the group responsible for registering deaths, births, marriages, and they maintain the vital statistics for the province. So reaching out to them gave us data about number of deaths that have occurred provincially, and that then was able to be subdivided into regions so that we would have the ability to compare deaths that occurred provincially, so the number of deaths overall provincially, to the number of deaths investigated by the coroner, and then on top of that, subdivide the ones investigated by the coroner with the involvement of the children's aid and without. So all of those different data sets allow the opportunity for comparison between. Now, having said that, this is a great first start, and I'm a big believer in data getting out there, but important also to understand the significance of data and limitations of data. You know, we've, I believe, articulated it very carefully throughout where limitations are there, but this is an overall caveat to describe prior to reading this and thinking about how the data should be analyzed. The data is not standard across all of the reporting by the coroners. It's not standard across the reporting to the coroner and reporting to the Ministry of Children and Youth Services. It's not standard necessarily on how Service Ontario has it. So there is some limits in the standardization. There may be some age differences on how they're grouped. So there are a number of things that can affect the analysis. Not to say that we should throw it out, but it is an area that needs to be thought about. And we have not confirmed the data, so we haven't gone down to each case and drilled down to make sure that that data is accurate. And there may have not been some data included in some case reports. For example, I'll give one example where you'll hear about later. The Office of the Chief Coroner does capture Aboriginal status, and that would be captured upon self-reporting. It wouldn't necessarily be an expectation that the coroner would track that or obtain that information. So we may have we may underrepresent the Aboriginal status deaths that we're involved with based upon the approach that's taken to collect that data. So we'll put that out there. And we also have variable presentation of the data provided through the approach from the reporting by the Children's Aid Society, not disrespectful of any approaches, just because of the fact that there is room for different approaches to be utilized by the agencies in the way that we obtain it. And then we're missing comparator data just because it's not available in different locations. So we're working to try to address those, and hopefully we'll have some of those addressed for the next annual report. But since we're going to release that in the next month or two, no, we're not going to do that. Just like to get Jessica all freaked out, because we did try to release that in June, but with my transition into the chief coroner's role and a variety of other reasons, that's why it's late, or later than June. And I suspect next year it will be somewhere between June and December. Next. So just looking overall at numbers, this gives you an idea of the number of deaths in Canada, being the top number. The pink would be Ontario, and then the coroner gets involved. So looking just at the Ontario data, there's about 1,000 and, well, around 1,100 deaths per year, somewhere in that range, and we investigate about 35% of those. So last year was 1,082, and we investigated 382, just to give you some perspective. When you distribute those across the age group, most of the pediatric child and youth deaths, and that's 706, so almost 68% of the deaths in the age group under 19 die under age 1. And that's not surprising. Those are the neonatal deaths that occur from complications of pregnancy, or they had some birth abnormalities, or they suffered some medical disease during that period of time. So we don't get involved that often in those because most of those deaths are, as I say, natural and will not fit into our category. So that gives you a perspective on the 1,083. And then you can see that our percentages across, which is we investigate, our red is our investigation in contrast to the purple, which are the deaths. You can see varying numbers. Under 1, not surprising, because I said not most would be natural. 1 to 4, 5 to 9, and 10 to 14 would generally be around the same range. 10 to 14 may be a little bit lower, but a similar percentage. Our percentage involvement jumps up in 15 to 19 because, again, less natural, more risk-taking, more homicides, more suicides during that period of time. So it just gives you an idea of what you see from a natural disease process and our involvement across the age range. And again, manner of death. Hello. Not surprising. Ours screen just faded. Not surprising, again, that our types of deaths will change over a range. Under age 1, many more natural still, but a huge number of undetermined, alluding back to what I talked about, how challenging it is, and how many of you know how challenging it is to give a definite cause of death under age 1. And then jumping up to the top of the bar graph, you'll see that suicide and accident and homicide clearly dominate over natural diseases in those situations. Next. So just to focus on deaths under 5, not going to spend too much longer with that, but we did review 112 deaths last year. It looks like I wasn't very active because we're 49% fewer than the 220 we had reviewed the year before. There's a number of reasons for that. One is probably because we had been doing a catch-up in 2012 for one reason, and also we had some case complexities and some personnel. We were reduced in numbers because I was in an acting role in the region, in the supervising coroner, in the chief coroner position for a period of time during that, and so my position was vacant. So there was a number of other reasons why our referral rate was probably down. So it's tough to know year to year what that actually means because the deaths under 5 reviews cases over a multi-year number. It's not a calendar year of deaths. So the number is very challenging to really interpret. We have two reviews. The full committee is made up of police officers, forensic pathologists, child welfare specialists, child maltreatment specialists, Health Canada, Crown Attorney, and a number of learners. And those will review the cases where we really are unsure what's going on, where the executive committee the executive portion of the committee will review cases that are straightforwardly natural and there's no outstanding concerns, or accidental deaths where there's no outstanding concerns. And so, again, not surprising, 49 of the 55 cases, well, not 49, but the majority of cases were, 49 were undetermined. Even with the full detailed review by the committee, we still weren't able to answer exactly how those kids died. Very unsettling for families, very unsettling for investigators, I'm sure unsettling for you as agency members when you're working with the families. But we can only say what we know, and we're basing our determination after a very thorough review by a number of different experts. And I can feel comfortable when I leave that table that we've done everything we can to try to answer those questions. We may have answers in the future, but honestly we don't know. And that could be because it's an unidentified cardiac problem. It could be part of a SIDS mechanism that we don't know exactly what's happened. There could be other medical problems that we haven't identified at this point, but we're continuing to do research, and molecular studies are starting to occur more frequently to try to better understand what those deaths are. And that's why we're collecting so much data on them, to try to better analyze and understand. So we want to know more, but we don't have answers anymore at this point. So essentially, I've talked about that already. Nothing further to say within that. So just very quickly to talk about SIDS. SIDS in Ontario last year, there was 0 SIDS in Ontario. Over the past number of years, there's been 1 or 2 at the most, and that is because we strictly apply the definition, which means everything needs to be negative when we define something as SIDS. And SIDS is the sudden infant death syndrome, and that's been in play and use in the medical terminology for many years, with a belief at this time that there's probably something immature about the development of the brainstem, which is where the breathing center occurs. That underlying vulnerability in a kid that we can't predict at a time where they're critically growing and developing, usually between 2 and 4 months, and then something else externally gets placed, the child is exposed to. The three of those combine and may lead to a child dying suddenly and unexpectedly during their sleep. There's no movement, it's a quiet death, nobody would have any idea that it's occurred, and the difficulty is there's nothing at the autopsy that allows us to identify that that's occurred. Again, everything has to be negative. It has to be a completely pristine sleep environment, and define pristine in the way that the medical field does right now, which is the barren crib. Not to be judgmental at all, but it's the crib with nothing else in it and the child on their back. But that has to be present. There has to be no other psychosocial risk factors and nothing else on autopsy for us to get this. In Ontario, we very strictly follow the definition. That is in contrast to other jurisdictions, and I'm not critical of either approach. I'm just saying what our approach is. And so that's why we get essentially 0. The agencies who advocate for families and help to learn more about SIDS find that very distressing, and they find that that suggests that there's been something nefarious done or something wrong done, and they believe at times not using SIDS is blaming the families. I just remind people that most of those cases are defined undetermined, and we don't know why they died, and so it's more of a general approach as opposed to specifically putting it into the SIDS category, but it may well be that in that undetermined it was a SIDS situation. There's a lot of research still going on, specifically in Boston around this, and we're hoping we'll have some answers about whether this in fact is the actual truth to how they occur, and then hopefully can try and find predictors on when they might happen. Next. So it speaks to talking about the continuum of death, and trying to figure out how you would characterize these. So SIDS, it's known that when there's cigarette smoking during pregnancy or after pregnancy in the house, if there's prematurity, if they're sleeping face down, and when it's hot, those increase they're associated with predisposing kids. And if you take about that the three circles overlapping, that doesn't need to be there, but it is thought to be one of the factors that would bring the three circles together. So that's a risk factor that allows the potential to directly affect the infant by their underlying natural abnormality. So there's perceived something wrong in their brainstem. That risk factor may allow that abnormality to demonstrate itself and lead to the child's death. Now, if you think about, say, sleep on a continuum, and you've heard this before, many of you, from the perceived safe sleep environment in the crib, and all data and all literature and all medical studies says that's the safest sleep environment, to the very dangerous one, which is the waterbed with 3 adults who are intoxicated while taking oxycodone and sleeping with their dog on a multi-blanketed, multi-pillowed bed with their 6-week-old infant. The very dangerous sleep environment. Where on that continuum, where does it cross to a potential death that has resulted? Okay, they can hear me still. So you might have lost some slides, but okay. So where it's changed from that natural disease as a potential SIDS to a true accidental death because of the sleep environment, the reality is we don't know. So what we capture is the data, and we just define it as the data. But what you've heard before is that sleep environments may lead, go to the next slide, may lead to the death. But what we in fact say, and we carefully say this, is infants die in an unsafe sleep environment, but we don't know if they died from the unsafe sleep environment. Having said that, we know the medical study and the literature does say that the sleep environment may well contribute or lead to deaths in infants. So we capture that on the death certificate, but still don't know whether in fact that is an actual cause of the death. And so it's an important classification. And the reason we can't do that is because there's nothing that we can find at autopsy or through our studies to say, yes, for sure that happened because of the sleep environment. And if you can't say that it happened that way, sometimes the history will allow you to determine that, but the reality is there's many other things medically which we've talked about, or I've talked about, which is the SIDS, the cardiac, the other disease processes. Those could equally have caused the death maybe I shouldn't say equally, they could have also caused the death, and we can't identify those. So because the autopsy doesn't give us a definite answer, we can't therefore use the history alone to decide that that's what the death has resulted from. So complicated, and you may have some questions arising from that, but it just comes back to what I said before. When the sleep environment is unsafe, it is utilized that the child has died in that environment as opposed to that sleep environment being the causative factor, because we just can't come to that conclusion. Next. When we look at the medical, again, I'm not going to spend any more time on this except for pointing out at the bottom that we typically have about 5 themes. They maintain. Healthcare system is a large system, and it's challenging to change things that occur in there, and there are a number of reasons why these themes will continue. We do draw them to the attention. We've certainly seen changes, individual changes in practitioner approaches, general changes in how pediatrics approach things. So there has been significant benefit over the years from us bringing these to the attention of the healthcare system. They take them seriously. They are interested. The themes do remain fairly consistent across the time, though. Next. I'm going to stop now. Everybody's going, thank goodness. And Jessica will take over for the next portion.
Thanks, Dirk. Okay, so Dirk's gone over some of this material already, so I won't belabor the point. But this year's annual report is split into 2 distinct parts. So there's a piece on the reported deaths, so those are the 96 deaths that were talked about, and there's a piece on the reviewed deaths. And so in 2013, the PDRC Child Welfare reviewed 34 deaths separately. The analysis that's done in this year's report is different, as we've mentioned, and we look at the child and youth population in Ontario, the number of child and youth deaths in Ontario, and the number of coroner's investigations, and then we split the subset, as we mentioned, into those with CAS involvement and those without CAS involvement. So when we're looking at the data that we have this year, and we look at sort of the 96 deaths of children and youth where a child welfare agency was involved, and we compare that to, there were 1,083 deaths in 2013 in Ontario. So the blue is the number of deaths in Ontario overall. The red is the coroner's investigations without CAS involvement, and the green is the number of coroner's investigations with CAS involvement. So we excluded natural deaths that we looked at only because the CAS was involved. Generally speaking, the coroner's office doesn't investigate natural deaths unless there's a care concern being raised. So for the purposes of comparing apples to apples, we remove those deaths from the subset. So actually what you're seeing is representative of 76 and not 96 deaths. So the proportion of coroner's investigations that had CAS involvement was around 25%. When we look at the age groups and we compare them, we noted that 5 to 9-year-old decedents were more likely to have CAS involvement before their death, and 15 to 18-year-olds were less likely to have CAS involvement. We didn't compare this to previous years, so we don't know if that's a trend over time or it's specific to 2013. And the other thing that I would say is, because we don't have access to data from the Ministry of Children and Youth on the number of children and youth that are involved with the child welfare system, because that data is collected on a family basis rather than an individual child headcount basis, we actually don't know if that's because more or less in that particular age group are served by the child welfare system, or because it has something to do with the mortality rate specifically. Next slide. So then we took a look at the regional distribution of deaths in Ontario. So again, green is the pediatric population in Ontario, blue is the number of deaths in Ontario of children and youth, and red is the number of coroner's investigations with CAS involvement. So when you look at it, the blue and the green are pretty much the same across each region. We use the regions that the coroner's office uses rather than the regions that the ministry uses. So I know that there are 9 regions for the Ministry of Children and Youth that I think they've now reduced to 5, and I know Children's Aid Societies are broken into zones. So for the purposes of this comparison, we just use the 4, Central, East, West, and North. Central includes Toronto. So when you look at the blue and green, they're roughly the same. And when you look at the red, it looks like there are differences across some of the regions. However, the only statistically significant difference that we found when we compared them was in the north. So in the north, about 5% of children and youth live in the north. About 5% of the child deaths that occur in Ontario occur in the north. But when we look at the percentage of coroner's investigations with CAS involvement that take place in the north, that number is 22%. So we know that it's higher. But again, because we don't have the comparator data on children and youth served, we don't know if that's because there are more children and youth served in the north by the child welfare system. We also don't know if that has something to do with the child welfare system in general, or because that's a more vulnerable subset of the population. So we know that there's lower health status in the north, there's challenges to accessing health care, there's higher mortality rates, and all of those things will impact on the number of children and youth that die in the north that have child welfare involvement. Next slide, please. So when we look at the manner of death of coroner's investigations with and without CAS involvement, if the well-being of children and youth across Ontario with and without child welfare involvement were equal, we would expect that the number of pediatric deaths occurring from a given manner of death would be the same in each category. So again, same as before, when we look at the different manners of death, it may or may not be reflective of the child welfare service. We know that the children and youth that are served by children's aid societies are in general a reflection of a more vulnerable set of the population. So when we looked at the data and we compared the two groups, we found that natural deaths occurring as a result of homicide, suicide, and accident were neither more or less likely to occur, regardless of whether there was child welfare involvement. The only statistically significant difference that we found was that where the manner of death was undetermined, those deaths appeared to be more prevalent where child welfare was involved. And again, we don't postulate as to why in the report. Thanks. So this was an interesting piece of our analysis. Historically, the PDRC has made multiple recommendations to children's aid societies relating to safe sleep education for staff and for families. They're making sure that children's aid workers, when they go out to visit families, are talking about safe sleep, which is all very, very important. Lots of children's aid societies have enhanced their training. They've, focused resources and supports to families with a view to preventing deaths in unsafe sleep environments. In 2013, sleep circumstances were identified in 37 of the 72 pediatric deaths where the manner of death was classified as undetermined. 14 of those children and their families received services from child welfare within 12 months of the death, and 23 didn't. So when we look at those from a statistical perspective, there was no significant difference between whether a CAS was involved and whether a CAS was not involved with that population. So there's lots of things that might impact that, but the absence of the difference could suggest that the practices of child welfare agencies in going out and talking to families and looking at safe sleep environments and providing information on safe sleep environments may have contributed to the overall prevention of pediatric deaths where sleep environment is a factor. So when we're looking at the 2013 deaths with CAS involvement, so again, we're moving back to the 96 now, to talk just briefly about the status of the children and youth. So 85% of the children and youth that died in 2013 were not in the care of a CAS. So 72 of them, the children and youth were living at home with their parents or other regular caregivers. They weren't the subject of placement. 1 was in residential services under a supervision order. 4 were placed in kin service arrangements. 14 were in the care of a CAS. 11 of those were Crown wards. 1 was a society ward. 2 were the subject of TCAs. And 4 out of those 14 were actually placed in residential services. We also had 2 reported deaths of youth aged 18 and under that were in receipt of CCSY, which is the old ECM, as I'm sure you all know. Thank you. So when we move on and we look at those 14 children and youth that were in the care of a CAS at the time of their death and the 2 that were in receipt of CCSY, they ranged in age from 2 months to 18 years. And of the 14 that were in care, the majority of those, the vast majority of those, were natural expected deaths, so 9 out of the 14. 4 were undetermined. Those were all infant deaths under 1, and 1 accident. For the 2 youth that were in receipt of CCSY, the manner of death for both was accidental, and in fact, both of those were motor vehicle accidents. Thanks. So when we look at the risk rating and the status of the files at the time of the death, approximately 70% of them were open, which means 30% of them were closed at some point in the 12 months preceding the death. More than 30% of them were rated as high risk at the time of death or case closure, and there were a number of commonly reported vulnerability factors. So for those of you that fill out the child fatality case summary reports, you'll be familiar with this. For those of you that don't, there are a series of vulnerability factors that basically get checked off as present or absent in the case. So interestingly, and not surprisingly, the most common vulnerability factor is verified abuse and neglect of the child or youth that died or and their sibling. So those are actually 2 separate data sets that are collected. The child and youth that died and their sibling are distinct. And the other one that we haven't seen before or hasn't been reported before in analysis in PDRC reports is the presence of physical or emotional disabilities. So that was the second most commonly reported vulnerability factor. Thanks. Also on that list of vulnerability factors, there are 3 vulnerability factors related to suicide. So those 3 are whether the child or youth has previously attempted suicide, whether they've experienced the suicide of a friend or relative, or whether they've spoken to someone about suicidal thoughts. Obviously, this data set is limited a little bit by what the Child Welfare Agency is aware of in the course of their work with the child and youth and their family prior to the death, and also in the investigation that happens after the death. However, we do know that 3 out of the 7 youth had more than one of those 3 vulnerability factors present, and 2 of them had previously attempted suicide, 2 had recently experienced the suicide of a friend or relative, and 2 had previously spoken to someone about suicidal thoughts. So this really speaks to what many of us are aware of, and we know that the Ministry of Children and Youth is doing a lot of work around youth suicide prevention right now, and that is that there are vulnerability factors present a good deal of the time. Thanks. So Dirk actually referred to Aboriginal children and youth and the limitations around what we know about how many of the children and youth that die in a given year are Aboriginal. So again, that's limited by self-reporting and what comes out in the process of a death investigation. Having said that, we do know that in 17 of the 37 deaths where the child or youth was identified as Aboriginal, there was also child welfare involvement, so around half. Of those 17 Aboriginal children and youth, 10 were involved with designated Aboriginal Children's Aid Societies, and the other 7 were involved with non-Aboriginal child welfare agencies. We don't know, because we don't collect the information, whether those non-Aboriginal Children's Aid Societies actually have units that address the needs of their Aboriginal local populations or not. 71% of the deaths with child welfare involvement that occurred in the North region were Aboriginal children and youth. 5 of the 7 children and youth that committed suicide in 2013 were Aboriginal, and none of the Crown Wards that died in 2013 were Aboriginal. So we talked about the Joint Directive very briefly, and I just wanted to go over really quickly when the Office of the Chief Coroner requests an internal child death review. So the death has to meet the criteria of the 2006 Joint Directive. When the child dies as a result of questionable circumstances, and or when the circumstances surrounding the child's death may relate in any way to the reasons for service or CAS involvement. So we get a fair number of questions about this, so I just want to talk about it briefly. That might mean we look for a CAS internal review when there's a circumstance where the CAS was providing prenatal service to a mom that was a substance user, and the child is subsequently born and dies, regardless of whether the birth and death of the child has anything to do with substance use, we might actually ask the Child Welfare Agency to take a deeper look into that death because of the fact that there was prenatal involvement there. And we see a number of other circumstances also. And if you have any questions about that, you can always feel free to ask. We also ask for reports and internal child death reviews so that we can take a look at the context in which the death occurred. It's an opportunity for individual child welfare agencies and the sector more broadly to learn from the child death and to identify areas of potential improvement. So we also get questions beyond around whether an internal review should be requested or why an internal review has been requested. We also get questions around whether a death is reportable. So we get a fair number of questions around deaths, whether deaths are reportable in circumstances where a child has died and, for example, never left the hospital. So is that a reportable death? And the answer at this point in time is yes, that is a reportable death if there was child welfare involvement prior to the child's death. So even in a circumstance where the Child Welfare Agency becomes involved between the time of the birth and the time of the death, and let's say for the sake of argument that's 12 days, and the child doesn't leave the hospital for the duration of that 12 days, we would still qualify that as a reportable death. And while we may not request a CAS internal child death review take place, we ask that to be a reportable death because it comprises part of the data set that we're looking at more broadly. So to put it bluntly, we wouldn't be able to do the types of analysis that we're starting to do now if we didn't have a complete set of reported deaths. Okay, so moving on to the child welfare reviews that took place by the PDRC in 2013. They reviewed 34 cases. None of the cases that were reviewed none of the deaths occurred in 2013. So as many of you will know, there's a time lag between when a death occurs, the coroner's investigation is concluded, the committee looks at the death, and as such, they were all in prior years, and I believe they ranged from 2010 to 2012. The age range was what you would expect it to be, 1 month to 17 years. And as Dirk mentioned, the focus of cases for review was primarily on deaths where the manner was undetermined, homicides, and suicides. 4 of the cases that were reviewed involved children and youth that were in the care of a child welfare agency at the time of their death. 2 were the subject of temporary care agreements. 1 was a Crown ward with access. 1 was in receipt of ECM, which is now called Continued Care and Support for Youth. And the manner of death for the 4 children and youth in care, 3 of them were classified as suicide, and 1 of them was a natural death. So through the case reviews that the PDRC Child Welfare undertakes, they track trends with a view to being able to see trends over time. So in addition to this, as I mentioned, child welfare agencies, when they complete the child fatality case summary report, they report on vulnerability factors associated with the child's youth or their family as part of their submission. And then the PDRC tracks a set of similar but not the same factors. So when we looked at those factors, the most commonly identified factors were consistent with what's been identified in previous years of review: caregiver capacity concerns, substance use, neglect or inadequate supervision, domestic violence, those cases with 3 or more CAS referrals, and the caregiver level of cooperation. So, you know, at this point, the factors are separate and distinct. In the future, it would, you know, I think it's our collective hope that we can align those factors so that we can use the data set and start to compare it in a little bit more of a comprehensive way. So when we looked at those factors, the most interesting thing that we came across was the presence of multiple factors. This is probably not a surprise to any of you, and it wasn't a particular surprise to us. In 3/4 of the cases, 5 or more of the 10 most frequently identified factors were present. In 35% of them, all of the 5 most frequently identified factors were present, so those are the factors that we just talked about. And in 1 case, all 10 of the most frequently identified factors were present. So as you can see, it's not usually just one thing. There's usually a number of things. But that doesn't necessarily speak to whether the death would have been preventable or could have been predicted. We just know that in general, this population of children and youth could be characterized as being more vulnerable. So looking at the categories of recommendation most frequently made to CASs, in 2013, they were pretty consistent with prior years. Improving training and practices related to safe sleep environments, incorporating relevant information into risk assessment and case management, facilitating case discussions with other community service providers, both before and after a death, developing, enhancing and providing training on suicide prevention, and collaboration with the mental health sector, practices related to case closure when there's risk factors and there's a notion that those risk factors may recur, improved discharge planning practices with hospitals for children and youth at risk of suicide and medically vulnerable children and youth. So these are the cases, the medically vulnerable children and youth, when we're talking about those, these are the cases where the child or youth has high needs. We know that the family that they're going back to may struggle in meeting those needs, but the child is released without a great deal of planning with child welfare or with the family around how those needs are going to be met. And so there's a little bit of a service gap there. And improving knowledge of and response to the impact of substance use on parenting. Thanks. There were 2 recommendations made to the Ministry of Children and Youth Services in 2013, that they continue their efforts to develop a strategic plan for Aboriginal child welfare, and that they consider a requirement for the development of fire safety protocols between CASs and their respective fire services. And if you are interested in the Ministry's response to those are located directly in the report, and you're welcome to have a look. There were also a number of recommendations made to other organizations. There were 2 made to the Ontario Association of Children's Aid Societies, the development of best practice guidelines related to approaches on case closure where there's a maternal pregnancy, and there is in existence now, I believe, a best practice guide or guidelines, and also that the content of core child protection training be reviewed to look at working with hard-to-serve and resistant clients. And again, that's a recommendation that's come up in previous years as well. There was one recommendation made to the Ontario Hospital Association that they work with Children's Aid Society. So this is similar to what we just talked about around discharge planning and information sharing around children and youth being released from hospital that are at risk of suicide. And 4 recommendations were made to a public health agency and 3 to regional supervising coroners that were unrelated to child welfare matters and had more to do with the processes around death investigation and death investigation immediately following a death. Thank you. Okay, so I'm going to pass it back to Dr. Huyer now to talk a little bit about the next steps on child death reviews.
So right now, and we're just in the end stages, in fact, so I should have corrected this, the office or the division we're almost complete in our process of developing a divisional strategic plan. And really what we've been working together both with, and some of you may have participated in this because we've done a far-reaching consultation to give us an idea of what would be the priorities for many others, including our priorities, so that we have a plan on where we're going to go over the next 5 years. We should have that complete in February-ish, maybe early March, and that will allow us to define where the death investigation system in Ontario is going to go over the next number of years. I feel strongly that data-driven public safety will be one of those key priorities, and along that path, we have not paused too many things, but we have paused a number of things. But one of them that we have continued to move forward on an incremental basis is how are we going to approach child death review in the future. And so we are looking right now. There's a number of factors that are going on at the same time. As you know, the joint directive has been in place since 2006. Jessica talked about some of the small issues that arise with it, but more importantly, we're trying to look and move forward from where we are. We now have a good understanding of many of the deaths that occur in the province, and many of the factors, as you've seen, are similar. It's really, can we take to a next level? And so we're working with the MCYS as one of our partners in that area to look at the joint directive. But you also likely know that Bill 8 has passed. It has not been proclaimed at this point, but the Office of the Provincial Advocate will have additional responsibilities to investigate, or opportunities to investigate, child deaths that fit under their mandate. And so how that's going to intersect with the work that we do, the legislation is quite clear that that is not to be done until after we're complete. But taking this as an opportunity and looking at things governmentally, so across, laterally across the system, how can we all work together to get the best information to help identify any systemic issues to try to reduce the chance of future deaths and improve systems provincially and hopefully nationally and internationally may arise from that. So with that as a context, we are in the process of looking at all of what we do now, looking at many other jurisdictions to see what they do, and we will move forward in the process of evolving the approach that we have in child death review over the next year or so. Next. Is one more slide, or is this the end? This is the end. So there you go. So we are on our next steps. We have taken a number of early work on that. You've seen some of the early work that's already been done to give you a bit of a view into it as how the annual report has been published and the different approach that we took this year in the annual report. And you've heard a number of different things about that. So 4 minutes before 11, we open up the floor for questions and comments, and Sean will direct us on how that's going to go. Sean did a lot of notes during this. I'm kind of anxious about what he was writing. We get a new hairstylist or something.
So yeah, as Dr. Huyer said, we will now open the phone lines for any questions. We would still encourage you, if possible, to make use of the chat box and type the questions, but we will now unmute the participant lines. Just as a reminder, hit *1 to unmute your phone line. You can then ask your question, and please hit *1 again to place yourself back on mute once you're done.
Participant lines unmuted.
So we're now ready for any questions, either in the chat area or over the phone line. And again, *1 to unmute, and *1 again to place yourself back on mute. Or Dr. Huyer and Jessica have done such a great job that there are no questions.
I'm noting that the participant number stayed at 92 from 94, so we didn't lose too many people, which is good to see. Hopefully this has been informative for you, and hopefully gave you some perspective on where we're at and where we're going. And we have a question being typed to us. Usually does take a minute to get to the computer and type them. So we'll just await the arrival of that question, and Jessica will respond, I'm sure. I do want to say, while that's occurring, I want to acknowledge, and I haven't done this yet in this talk, I want to acknowledge all of the work that Karen Bridgman-Acker did in the area of pediatric death review, and also the intersection between the Office of the Chief Coroner and the child welfare sector. Without Karen's work, we wouldn't be where we are now. She did a phenomenal amount of work of bringing the intersection together between the two areas and really clarifying and providing a good framework and focus on that. And so I want to acknowledge all of that work that Karen did over the years and all of the value that she's brought to the child death review work. So thank you, Karen, and I'm hopeful that everything is going well for her right now. The question, do we read them out, or can everybody read them? So the question is, do you find that children's aid societies are providing adequate information to assist your work? Are there any recommendations you can make around this area? And yes, that will be Jessica responding.
So I appreciate that question. I think based on what we're requesting and based on the joint directive at this point in time, by and large, yes, the information that we're getting from children's aid societies is adequate, if that's the word that you want to use. I think children's aid societies make a great deal of effort to be thorough and responsive when they fill out the child fatality case summary report and when they go about conducting internal reviews. I think the quality of those reviews, I know the reviewers on the Pediatric Death Review Committee frequently have commented on the quality of those internal reviews and the information that's coming in from child welfare agencies as steadily improving. So I wouldn't say at this point that there's any recommendations that we would make, particularly because I think as we move forward and we sort of look at the next iteration of child death review, that might be sort of a more appropriate place to address any gaps that we see. But I would also say that where we need clarification or more information, I've been really, really fortunate to develop great working relationships with a lot of the child welfare agencies since I came into this role in June, and I appreciate how responsive folks have been when I call and need some help to understand something or I'm looking for something. It's been really good so far, so thanks for that.
I get the next question. Can you offer a definition of medically fragile? And you're welcome, Ms. Livingston. On Jessica's behalf, can you offer a definition of medically fragile is the question that was posed. I first will, for a reference, to take some, if you have the opportunity to go back to last year's, so that was the annual report of 2013, and take a read through the section. There's an article talking about the intersection between the healthcare system and the children's agencies, or child welfare agency or sector. Take a chance, take an opportunity to read that because it really gives you some framework around this question. It really depends on whose reference point you're looking at. The reference is from the physician's point of view, so a healthcare point of view. Medically fragile means they're probably going to die in the next little while. And they're not likely going to get out of hospital, or they're going to require substantial services. From a child welfare perspective, it's been my view that medically fragile has been often utilized to define a child who's got some medical illness. They require a number of additional services, but they're not in the fragile to they're going to die perspective. So it's really a poor term to use, and I would encourage you not to use that term because it's so misunderstood between the two sectors, and clearly this is one that you want to be clearly understanding because you are going to be intersecting with the healthcare sector whenever there's a kid who has medical needs. So I would really avoid that terminology if you can and get to a more defined approach to what is really the services. So a child who has medical needs would fit more generally and it's the extent of those medical needs. So that's what I would encourage you to do with that. The next question is, an undetermined cause of death means what exactly? Isn't there always a cause of death? The answer is no, we can't find a cause of death when we say it's undetermined. It means exactly as it says, not to be to say anything differently, but it means we can't determine one. And so that's a very challenging situation because if we can't determine the cause of death, it means we can't determine the manner, which is either suicide, natural, homicide, or undetermined. So when the cause of death is defined as undetermined, means we don't know if it might be a natural death, it won't be a suicide typically in an infant, it won't be a suicide in an infant, could be a homicide potentially, could be a natural disease. And I'll give you an example of an infant death. So if we can't determine the potential list of things that it could be are one, so say it's in a sleep environment. So an unsafe sleep environment is where the child is found dead. The child could have died from the unsafe sleep environment by their airway being blocked, and so it's an airway blockage mechanism. They could have been suffocated by somebody pushing a pillow over their head. Not do I think that that's likely occurred, but that would give you exactly the same autopsy finding. It could be a SIDS kind of death. It could be a cardiac kind of death, because none of those things will show up at the autopsy, and therefore we can't determine the cause of death, and therefore it will be undetermined, and therefore the manner will also be undetermined. Because if you take my scenarios, the airway being blocked by the pillow is a homicide. The turning into a pillow would be an accident. The SIDS would be a natural. So we've got those three categories that we can't differentiate, and therefore we give you undetermined. So I hope that helps a little bit. So the next question, can we please elaborate on what some of the preliminary recommendations are improving for preventative services in Northern Ontario, aka the North? We haven't actually made any specific ones that I recall, but I look to Jessica for that.
No, so we haven't made recommendations on improving preventative services in the North. So if you read the annual report, we do acknowledge that there are differences in the availability of services in the North, and we talk about the fact that that might impact on the higher percentage of child and youth deaths with CAS involvement in the North. But the role of the PDRC at this point in time is generally to make recommendations to children's aid societies directly. I don't think, I know for sure in 2013 there were not, but I don't think generally speaking that the committee takes on making sort of broader recommendations around preventative services. I think that would be a little bit perceived as a little bit out of scope at this point in time.
And just to build on that a little bit, we're death investigation experts. That's our job. We have the expertise to fully understand, but as you heard in my answer to the undetermined, sometimes we don't find them, but we do our best job to find out and understand the circumstances of the death. And then if we recognize a particular issue, that would be something that we would raise for consideration through a recommendation to those who may have the ability to further understand the circumstances through their own internal insight into issues that might be the focus of the recommendation, and then using their expertise and their approach and knowledge to decide whether they're going to respond to that recommendation. So because we make a recommendation doesn't mean that we know that we have a fix, and it's not, we don't have the expertise to fix things, and so we don't have the insight to be able to fix them and therefore be prevention experts, but we bring those forward to others. So next question, to check my understanding, an undetermined death where factors such as smoking, overheating, etc. could be present are not being listed as SIDS. Now, if in fact, so is that a change? Does that mean there's a decrease in the number of deaths being attributed to SIDS? And over the past 5 years, actually 6 years, our numbers are very similar, either 1 or 0. There might have been 1 year with 2 SIDS. Now, we've provided the same approach to the application of the definition of SIDS over many years. If in fact the child was found dead on their back in a crib that was defined as a safe sleep environment, and there were no risk factors such as child welfare involvement, any other concerning factors in the house or anywhere else, and smoking and overheating were factors that were present, those would be listed as a SIDS, because smoking, overheating, and prone positioning, so sleeping face down in a safe environment, are recognized as true factors that can occur with SIDS. So if everything else was negative and those factors alone were present, they still would be defined as a SIDS. So the issue has been is that those factors are present as well as many others. So the sleep environment is not safe. There's other risk factors that are identified. There's psychosocial concerns. There's other findings at the autopsy that take it out of the level of SIDS as well. So that hopefully clarifies a bit for you. Methadone is a huge problem regarding risk factors in child welfare. It's a bit of a challenging question, and huge problem means that we have the data to answer that. Certainly there's information that suggests that methadone is not uncommonly seen in child welfare situations, but I think we have to be careful and use data to be able to answer whether it is a huge problem and what that relates to otherwise, and how that affects whether methadone use is a risk factor, or more importantly, the reason that somebody's on methadone, which would be substance use, that would be more likely the risk factor than methadone. Having said that, I don't want to drill any further down without further data. And so what work do you recommend be done with the methadone clinics? Well, I'll tell you the one thing that we have recognized, and I do think is an important one, is bridging the gap of understanding substance use and the risk that may lead to child welfare, to difficulties within families and your child welfare work. So Jessica will likely build on this a bit more, but just to tell you that what we do recognize is methadone clinic providers are addiction treatment specialists. and they have a reference point that addiction is a health issue, and that reducing the risk, reducing the potential that somebody will attend for addictions treatment by reporting concerns about their addiction to an outside agency. So in other words, they're worried that that because of this medical problem of addiction, they're getting treatment for it, and you might interfere with the treatment relationship by reporting to the Children's Aid Society, and the fact that they think that this is something that should be managed medically as opposed through the legal system and the child welfare system. That is something that I have seen as a theme, and what I would encourage you to do is to reach out to any addiction treatment clinics on a proactive information sharing discussion perspective, as opposed to necessarily, you do have to do it on a case by case, but to step outside of the case and look at it more generally to build a relationship and an information sharing approach with addiction treatment clinics that are present within your jurisdiction. So that's my recommendation on that. Jessica, anything further?
No.
Phew. So that's what I would recommend on that area. What kind of communication is occurring or will occur with Midwives Association about safe sleep environment? Different information is being provided from parent to parents, and this creates confusion. Directions for a safe sleep environment and co-sleep can be outside of recommendations. And so we don't own this. We are data providers, and our data is, we don't make specific recommendations about sleep environments. We provide data about deaths that occur within sleep environments, and it's really the field and the experts and the people that are involved with the families that need to develop the recommendations and the directions. So there's been recommendation to the agencies to define their approach to safe sleep instructions and how to enhance the education around that made by us, but we don't provide the directions on how that should be done. So similarly, we would not we are not in a position, nor will we take the position, to unify the information. And frankly, the information is variable from different perspectives. So there is literature that will give you differing information. There is solid literature-based, medically based data that shows that sharing a bed with an infant reduces the physiologic stress of an infant. So the heart rate is measured to be lower. There's data that supports that bonding is enhanced, and I don't know how strong the data is on the breastfeeding, but there is certainly anecdotal evidence that it supports that breastfeeding is better. And so people who have that reference point are going to be supporting bed sharing, whereas the reference point of somebody who does death investigation and medical perspective where they see that risk, there might be a reference point that's different. So that's why we're bringing this forward in a concrete way so that people have information. What I would encourage you to do is to look at the Registered Nurse Association of Ontario, the RNAO, and they provided what I would describe as a very good document that discusses all of those issues that I've just talked about and is literature-based and evidence-based. And then I would encourage you to reach out to the Midwives Association locally and have a conversation, again, not around a case necessarily, it might be your trigger, but more on a higher level discussion so that people who are with a new child have the ability to be informed about the risks and benefits, and they make their own decisions in an informed manner. So as opposed to telling them what to do, letting them make decisions, we've provided the data as you've seen, and the caveats that are there. And so I would encourage you to reach out to the RNAO, because the document that's available through the website, Registered Nurse Association of Ontario, it's one good example. There are others that give it's a discussion. It's an evidence-based and a literature-based discussion about how to approach this particular issue of safe sleep with infants. And that, I think, would give you a good guide and provide you the opportunity to reach out to the midwives and have a information sharing discussion. Not that anybody's going to be able to necessarily say one way is the right way or not, or the wrong way. I hope that helps. Do you want to add anything? Sean, you want to add anything on that?
I'm good. Thank
Emily?
you.
No? Okay. Well, we're all good in the room here anyway. Well, we'll draw to a close unless there's any other questions that people have. Greatly appreciate your participation, both today, but also as Jessica, just to build on what Jessica said, over the period of transition over the past year, but also on a case-by-case scenario. These are very challenging cases when they occur. I certainly believe I have some perspective on how hearing that news in an agency, especially when you've been providing service to that family, would be received. I clearly can't know how everybody would feel, but I can certainly acknowledge and understand how challenging that would be. We do recognize that, and we appreciate the hard work that you do, both in the situations when you're providing us the reports, but also the additional work and probably some of the challenges that occur when the internal reviews are done, because of the focus that may come upon you and the questions that are asked to try to understand those more effectively, and also when you're receiving our reports. Thanks for your careful consideration of the recommendations and your responses, because that's greatly appreciated. We don't always get it right. We think we're pretty good, but we don't always get it right, and sometimes it's outside of some of the context that you have, and so that's why we direct them back to you, and you have the opportunity to think about those within the context of your agency. So thank you for all of that, and thank you for all the hard work that you've done and with us over the past year and historically as well.
Thank you, Dr. Huyer, and Jessica, for joining us today and providing such good context on the 2014 annual report of the PDRC and Death Under 5 committees. This concludes today's webinar. Thank you for your participation, and have a good weekend, everyone.
I'm coming home, tell the world I'm coming home, let the rain wash away all the pain of yesterday. I know my